Perfect. Hi, Dr. Evans.
Hi,
Thank you for joining, everybody. Thank you for coming. I just wanted to make a quick announcement before we get started. These lectures are being recorded, and after all of our lecture series are complete at the end of the month, we'll kind of send out a mass email to everybody who's participating, who's unable to make some of them, and just let them know where they're located so they're able to go back and watch them. But without further ado, Dr. Evans, if you want to take it away, we appreciate you being here.
pleasure. Yeah, it's great to have Pancreatic Cancer Awareness Month on November. I'm unfortunately I'm looking at myself now, and it's a pretty ugly face to be looking at on my computer. I don't know if there's a way to get everyone else on there for my view. I don't know. Is there a possibility for me to do that so I can look at everyone else? But either way, it doesn't matter. You're much better to look at than me. I can tell you that, Olivia. Thank you, but thank you all. I think I was down to talk a little bit about treatment sequencing, and maybe I could talk for 10 or 15 minutes, and then we could do a bunch of questions. We also have this thing called Pancreas School, and I would invite everyone to go to YouTube and search Pancreas School. And there is a video there on treatment sequencing as well. But maybe I'll start initially with I think Olivia Dewey, and I think Melissa is under the weather. Melissa, I hope you feel better. I
Thanks.
I saw I saw
Recovering.
her. Yeah, you poor thing. Gee whiz. I think, did we have someone talking about staging at all this month, Gino?
I don't think
I
so.
Yeah.
don't think
It's
so. Mm-mm.
yeah, it's hard to do it sometimes without slides, but we have a pancreas school on staging too. But in any event, I will confine, well, I can actually cover all of the stages. So it's fascinating that if we go back to the history of surgery for pancreatic cancer, initially even when CT scanning was first being developed, it was difficult to determine if the primary tumor was removable or not. And so, therefore, patients oftentimes went to the operating room, and the surgeon would then determine whether or not the primary tumor could be removed based upon some relatively unsophisticated techniques of assessing and feeling tumor blood vessel relationships. And then, really, in the late 80s and early 90s, when CT scanning became very accurate, one could then determine whether the primary tumor was surgically removable before the operating room. And in fact, we also got fairly good at determining whether the cancer had spread to other parts of the body, most common the liver or the lining of the tummy, called the peritoneum. And because our advances in chemotherapy probably lagged a little bit behind advances in imaging, CT and MRI, um, for patients whose tumors were thought to be surgically removable, they were typically brought to the operating room first. And then if the pathology was not what we wanted, if there were multiple positive nodes or a positive margin, they would then be given chemotherapy after the operation. And oftentimes that was also followed by radiation therapy. For patients whose tumors could not be removed in the operating room, they would oftentimes get radiation therapy after surgery, sometimes also with chemotherapy. We became interested in changing that paradigm now probably 30 years ago, in an effort to advocate for those patients who may recur soon after a big operation. As the operation gets larger in magnitude, um, we if anything, feel even worse when the cancer comes back right after a big operation. I think all of us can appreciate the fact that the cancer may come back after successful surgery for any solid tumor. But if the operation is relatively small, for example, taking your appendix out, that has little impact on someone's quality of life, as opposed to a Whipple operation, for example. So, in an effort to try to find those patients who had more aggressive tumor biology, we began giving chemotherapy and radiation prior to surgery about 30 years ago. And again, when we first developed this, it was in an effort to kind of find those patients who were destined to have recurrent disease and therefore would not benefit from a big operation. I think all of you can appreciate that one of the big concerns of any cancer doctor is to make sure that the treatment is not worse than the disease. I kind of learned this lesson when I was actually in medical school, and my wife and I were engaged to be married, and so I had to go over and kind of run the gauntlet of her grandfather and her uncles. So these were all hopefully. I can't ask people to raise their hands because I can't see you, but for those of you who are Irish on the call, you'll appreciate this. So I had to deal with her grandfather and uncles, plus a large bottle of Jameson. And I'll never forget her grandfather saying, I don't know about this medical school idea. The guy who delivers our mail, great guy. He had an operation for cancer, and the cancer came right back. And I'm not sure the doctors did anything. And what he was actually conveying is that in this case, the treatment was worse than the disease. And we obviously never want that to happen. So when we first started changing the sequencing of treatments for pancreas cancer, it was in an effort to prevent the treatment from being worse than the disease for those patients who we knew, and it was a fraction of the patients, typically in the range of about 20%, who experienced early recurrence after a big operation. So we said, well, can we give a few weeks of chemotherapy and radiation prior to surgery? After the chemo and radiation is complete, we would repeat the CT scans. If there then was disease in the liver or the peritoneum or the lung that wasn't apparent at the time of diagnosis, we would obviously be saving that person from an operation that would provide no benefit. As our treatments for pancreas cancer have become orders of magnitude more effective, the reason now to give chemotherapy prior to surgery is because we're much more effective at curing cancer when it's small in numbers. So for those patients who may have a few cells, cancer cells in lymph nodes or in other parts of the body at the time of diagnosis that are beyond the resolution of any imaging study, be it CT, MRI, or PET, chemotherapy right away, as opposed to delaying it until after the operation, may be more effective. And studies have now shown shown a survival benefit for those patients who receive chemotherapy prior to surgery, as opposed to after surgery. Obviously, as many of you know who are patients and who are family members of patients on this call, it isn't straightforward or easy to recover from a big pancreas operation, and therefore one cannot reliably count on the delivery of chemotherapy after surgery, as opposed to at the time of diagnosis. There oftentimes are very few impediments to the delivery of chemotherapy prior to surgery. So that's how I would frame the chemotherapy approach. I think right now there's general consensus around the world that the first treatment for pancreas cancer, regardless of stage of disease, should be chemotherapy. I'll get to radiation therapy maybe in a second. I think because now patients can be diagnosed by a combination of their family doctor, a gastroenterologist, and a medical oncology consultation without necessarily seeing a surgeon, they oftentimes will be started on chemotherapy once a pancreas cancer diagnosis is made, which is great and represents the right treatment. But their stage of disease and therefore the goals of therapy may not be clearly defined. And we see that not infrequently, especially with our second opinion program, where patients are receiving a few months of chemotherapy. It's not particularly clear what the goals of treatment are. In other words, is the plan to go to surgery? Is the plan to give radiation therapy prior to surgery? How long should the chemotherapy be given? As all of you know who may know me, we try to encapsulate the answer to all of these questions in clinical trials, and the clinical trials, of course, test new therapies, new sequencing of therapies, and also are very specifically defined in what the treatment is. So that's how I would summarize chemotherapy. One of the unintended consequences of general consensus that chemotherapy is the first treatment for most all stages of pancreas cancer, either on or off of a clinical trial, is that patients who are treated off of a clinical trial, oftentimes their stage of disease may be somewhat ambiguous. Whether the tumor is operable may be a little bit of a gray zone category. And therefore, the duration of treatment and the goals of therapy could potentially use a little tightening and clarity. The last thing I wanted to cover before we maybe go to some questions is radiation therapy. I work at the Medical College of Wisconsin, which has one of the best departments of radiation oncology in the world. It's been an area of strength at our institution for decades, and really a lot of the techniques for modern radiation therapy have been developed here. It's really fascinating. We have championed the incorporation of radiation therapy in the treatment of patients with operable pancreas cancer. So typically our clinical trials, and even in patients treated outside of a clinical trial, they typically receive radiation, they typically receive chemotherapy and then radiation and then surgery. The goal of radiation therapy is to sterilize the periphery of the tumor because the pancreas was put in a pretty crummy location. There's a lot of important real estate where the pancreas lives, a lot of important blood vessels and other organs. So unlike, for example, a tumor in the breast or a sarcoma in the thigh or a cancer in the intra-abdominal colon, where you can take out a large amount of surrounding tissue, oftentimes the amount of surrounding tissue that we remove at surgery is relatively modest in amount, so the margins can be somewhat tenuous at times. Radiation therapy has been clearly shown to increase the likelihood of having negative margins after surgery, and also reduce the likelihood that the cancer will come back in the area where the pancreas cancer used to be, so-called local recurrence. Local recurrence rates are reduced by at least 50% with the addition of radiation therapy. You might ask then, why has radiation therapy been so controversial in the treatment of pancreas cancer? And it's largely because pancreas cancer has a dominant site of recurrence, that being the liver, less commonly in the abdomen or the peritoneum, and also in the lung. Obviously, if the cancer comes back after surgery in the liver, for example, the disease in the liver will oftentimes be responsible for how long the patient will live. And if there is a recurrence in the site of the tumor where the surgeon operated, in the setting of cancer in other parts of the body, it may not have a major impact on length or quality of life. Those patients where local recurrence are most significant are those where that's the only site of recurrence. In our experience, where we include radiation therapy prior to surgery, the likelihood of what we call local only recurrence is in the range of 8 or 9%. And in those centers where radiation therapy is not included, the likelihood of that local recurrence is 2 or 3 times higher. So for those reasons, we still feel that radiation therapy has a major role to play in patients with operable pancreas cancer. And obviously in those patients whose tumors are inoperable and they can't be removed with an operation due to local anatomic factors, radiation therapy has a major role to play and is less controversial. So maybe with that, since I've spewed on for about 15 minutes, I know that when I've done these in the past, the interchange has been probably more important and more helpful than listening to me. So Melissa, is that or Olivia, is that an
Yep,
okay introduction?
that
And
sounds good. I
we can
wanted to
go from there.
see, yeah, I can navigate you if you want to change your view. I don't know if you could still see everybody or not. If you click at the top of your screen, you'll see a little thing that says view. And if you drop down, you can
Oh yeah,
hit
sure.
gallery or multi-speaker, and you
Oh
should be
yeah,
able to see
perfect.
everybody.
Great.
It
Thank you,
does look,
Melissa.
yeah, no problem. It does look like we have a couple questions. I see
Oh
Candace
yeah.
has a question as well as Debbie. I'm just going to shout out Debbie's question really quick, and then we'll move to you, Candace. Is it clear that a pancreas cancer metastasized to the liver is inoperable?
Usually that would usually be the case. I think certainly that in those patients where we eventually operate on the primary tumor, it's usually and there is a question of metastatic disease in the liver. It's usually that situation. In other words, a patient who presents at the time of diagnosis and has 1 or 2 tiny spots in the liver which are simply too small to know. If they're less than a centimeter in size, for example, it can be very hard to know, is that a little focus of cancer or is it not? The other thing that complicates the liver is that many patients with pancreas cancer have an obstructed bile duct, and they therefore need a stent put in the bile duct. Whenever we introduce a stent in the bile duct, we allow the bacteria from the intestine to get into the liver, which normally is not the case. And the patient can get tiny little abscesses in the liver, which can be very hard, sometimes impossible to differentiate from tiny little metastases. So if a patient receives a few months of chemotherapy, and the liver either all becomes normal, in other words, 1 or 2 tiny spots go away, then oftentimes the primary tumor would be removed. So the way I would answer that question is the only patients in general in whom we would take out the primary tumor where there is a concern over a disease in the liver is when we can't tell, and the spots in the liver are so tiny that it's impossible to know.
Great. Candace, you want to go ahead?
Yes. Hi, Dr. Evans. This
Hi.
is Candace from Memphis. We actually spoke last week about my husband, David Ferguson, here in Memphis. I know you speak to a million patients, but I'm finally meeting you face to face. But my main question is, when you were speaking so much about radiation and radiation therapy, I just don't understand why radiation has not been an option for my husband. Why no doctor will do radiation.
Yeah,
So,
I think Candace, correct me if I'm wrong, and it's been a busy last 10 days, so my memory may not be what it should be. But did we arrange for an appointment somewhere else for you? Did-
You were going to reach out to someone here in Memphis.
Yeah, I think we may
Yes.
have had success. I think we may have had success, but so you know what to do is I would give Gabby a call as well, and because I think we may have had success there.
Okay.
So
I
maybe
guess my question is, what makes someone not able to do radiation? Why is radiation an option for so many and it hasn't been an option for him?
Yeah, I don't remember the details of your husband's situation, but again, it goes back to the treatment and the disease. I think whenever we apply a local therapy, so a
Mhm.
treatment that does not treat the whole body,
Right.
um, we want to have some, and there's no way to have a guarantee, but we want to have some good faith estimate that the patient will live long enough to benefit from it.
Hmm.
And so, obviously, you want if you're going to put someone through uh, the the pain and recovery that's involved in a big operation, you would like them to live long enough to benefit from that. And radiation therapy kind of has a similar thought, is that with pancreas cancer, if we're going to have someone spend a few weeks going to radiation therapy, even though the side effects should be quite manageable, we would want them to live long enough to benefit from that. And I think that's where some doctors have been a little bit hesitant to apply radiation therapy, perhaps where we would. It's not uncommon that we would radiate the primary tumor, even if there might be small volume cancer in other areas, the lung, the liver, etc. Because what really is important is how long we estimate that the patient will live. And obviously, the longer they live, the more the primary tumor becomes at risk. If the primary tumor gets larger, it may cause pain. It may cause an obstruction of the duodenum, so that eating may become more difficult, etc. So this gets into a little bit of the art of medicine. I think here we tend to be a little bit more open-minded with regard to kind of more traditional dogmatic rules. And then we also have a very robust weekly conference where all the doctors interested in pancreas cancer get together for an hour and a half every Friday morning, and we talk about these things. We talk about the patients, and I think we come to consensus and agreement over this. But that's how I would answer that question.
Okay. Thank you.
And I know Gabby has a go-to medical oncologist now in Memphis. So we've had some email. This has all happened over the last 24 hours. So
Yeah.
just give her a call.
Thank you.
Okay.
There's a couple questions in the chat here. One of them was kind of going back to the first question about metastasized liver. So someone was asking if you're recommending that a metastasized liver cancer should be treated with radiation and chemotherapy if the tumor is inoperable.
Typically what is done if is that patient would get some type of systemic therapy. So a treatment that treats the whole body. Chemotherapy is designed to kill cells. There are other therapies now that are being developed, just a whole myriad. But by systemic therapy, we mean treatment that goes through the vein or through your mouth and treats the whole body. So a pill, a tablet, or an intravenous infusion that treats the whole body. In general, when we have cancer outside the pancreas, so it has spread through the blood through the lymphatic system to other parts of the body. We would typically treat that with systemic therapy, an intravenous infusion, a pill, or a drug. Just recently, within the last couple years, there has been a renewed interest in treating very limited cancer in the liver that has spread from the pancreas with radiation. So most notably in those patients who have had surgery for their pancreas cancer, and then 2-3 years later, the cancer may come back in the liver, for example, and they receive, say, an additional 4 to 6 months of chemotherapy, and they have 1 or 2 spots in the liver, and that's all they have, and nothing has progressed. There's renewed interest now in maybe treating those couple spots with radiation. We have historically treated lung metastases, so pancreas cancer spread through the bloodstream, ends up in the lung. Lung metastases often occur sometimes, 3-4 years after surgery. Those were frequently treated with radiation if they were relatively small in number. Unlike the pancreas, where we can give a big dose of radiation, you can't give a big dose of radiation to the whole liver or to an entire lung. You can give a treatment dose to a small area in the liver, a small area in the lung, but you can't treat the whole liver. So you have to be fairly careful with it. So right now, the whole world is trying to decide when to apply what we call local therapies like radiation, and when to and when not to do that. So it's really an exciting time in oncology as we're trying to put all of these treatments together. I think one of the things that we try to do is to provide help in strategy, in developing overall treatment strategy. Most all treatments can be successfully delivered closer to home, but I think the strategy sometimes it's helpful to get a number of minds on the case.
Thank you. Our next question, Dr. Evans, do you have an opinion on histotripsy?
Well, this has just gotten started. It's this is basically like sound waves that are used to basically obliterate the tumor. And it's probably most appropriate for tumors in the liver. I think that's where it's being applied right now. And I think with pancreas, I think the problem is the blood vessels and the intestine that is adjacent to it. So where this will all shake out with pancreas cancer, I think we'll have to see.
Thank you. Another question, does adjuvant chemotherapy have a place in the treatment plan following total pancreatectomy with complete pathologic response?
Oh boy, great, great question. All of you are very well educated. I think that that probably is a debatable subject. I think if you go to Pancreas School, Dr. Kamgar and I, mostly her, put a video together on adjuvant therapy to highlight one of our clinical trials that she is running and that is supported by the Sina Magowitz Foundation. It's a clinical trial of targeted therapy after surgery. So I can tell you what we do here, for example, is if we have someone who has received chemotherapy, radiation, and surgery, and so the tumor was removed, obviously there's not a guarantee that the cancer won't come back. We would love to have a world where when we did that, the cancer would never come back. But unfortunately, with pancreas cancer, that isn't the case. We're getting better and better all the time, so that now the likelihood of the cancer coming back is approaching 50%. I mean, somewhere in the 50 to 60% range. For other diseases, that would be high. For pancreas cancer, the thought that with chemotherapy, radiation, and surgery, we may cure 40 to 50% of patients was something 15 years ago never thought possible. So we've made amazing advances. But what we do, for example, is we have what we call restaging meeting or a reassessment meeting at 6 to 8 weeks after the operation, where we repeat the CT scan. We look at the pathology report. We typically do genetic profiling of the tumor taken in the operating room. And then we usually look at circulating tumor DNA, both in the operating room at the time of operation, as well as 3 weeks after surgery. So we then have all of that information. Obviously, if at the time of operation, when we took the tumor out and it gets analyzed by the pathologist, there was no viable tumor there, then there's no way to look at the genetic mutations in the tumor. But if we have a situation where the pathology report is very favorable, and obviously no cancer in the specimen is the most favorable pathology report that you could ever have. And if also there is no evidence of circulating tumor DNA in the blood and the tumor markers are all normal, we in general would probably not do anything after surgery. Sorry for a little bit of a long-winded answer, but I'd also look at the video on Pancreas School because we go over this in some detail.
Thank you. There's a follow-up question to the first question again. If the primary pancreatic and liver cancer have disappeared with chemotherapy, and then a 2 by 3 centimeter tumor has reappeared in the liver, what is the proper treatment paradigm in your opinion?
Yeah, I think in that case, we would probably biopsy the liver and confirm that that's exactly what it is. And we could also do sequencing on that. And that may be a situation where radiation therapy to that liver lesion would make sense if that is the only possible lesion that's there. In patients who have had a lot of chemotherapy, so that their ability to tolerate more is starting to shorten. In other words, the neuropathy in their hands and feet has become significant. Maybe their cell counts are challenging. There certainly is a role for having a chemotherapy break, and sometimes radiation therapy may help. One of the areas that we're particularly interested in is looking at oral medications that are designed to target the mutations that are in the tumor. And that's why now pretty much everyone who has pancreas cancer, we try to acquire blood and tumor tissue so that we can look at the genetic mutations that are in one or both of those. So I think in this case, in general, and again, my answers are always, generalized, we would probably see if we could biopsy the tumor and then go from there. I think one of the general principles in oncology is when things are a little unusual, it's always important to know exactly what you're dealing with. So when possible, we would always be fairly liberal with the use of biopsies.
Thank you. Another question that came in, I am a newly diagnosed and the PET scan said no metastasis. The CT did say I had cysts in my liver. Could those be confused with cancer?
They could be, but normally cysts are pretty common in the liver, and they're usually not like ultra tiny. The PET scan has a resolution of usually around 8 millimeters or so. So if there is a tumor that's larger than about 8 millimeters, we would normally expect it to show up on PET scans. So I think if the cysts in the liver are thought to be cysts based on CT or MRI, the radiologist is probably correct, and they're probably cysts.
Could I ask another question?
Sure.
I'm in Arizona. I'm Karen, and I'm going to Dr. B, and I do believe he's going to refer me to you. And at this time, they're only talking about chemotherapy and then surgery. If you recommended the radiation after the chemo, would I do that in Wisconsin or in Arizona?
I think it depends on you know your how you feel about spending a few weeks in the great state of Wisconsin. You know, I'm a little sad that all this political stuff is over because Wisconsin was getting so much attention. I think we're gonna have a withdrawal of attention here in Wisconsin. Obviously, I'm joking, but I think it could be done in either location. We have I'm particularly fond of our radiation oncologists just because they're just wonderful people. They have a real interest in this disease. We just established the Bob Euchre Chair in Pancreatic Cancer Research. For those of you who are baseball fans, I see an LA hat there. You probably recognize the name Bob Euchre, and the person who holds the chair is actually a radiation oncologist, Bill Hall. I don't know, is Bill down to give one of these sessions, Melissa?
We have reached out to him and no response
Well,
from him yet, but we were trying to recruit him.
okay.
I
Well,
think
Olivia, I would not
Dr.
allow him.
Erickson is.
Yeah,
Okay, I
Dr.
would.
Erickson is.
Oh, good. Well, I would not allow Dr. Hall to say no, especially now that he holds the Bob Euchre Chair in pancreatic cancer research. But I
Okay,
think,
I'll let him know that.
yeah, I think they're a very good radiation oncologist anywhere. So either option I think is fine.
Thank you.
All right. Another question. What is the additional benefit for chemo treatment after Whipple surgery and not only chemo before surgery?
It's a great question. I think what we do is uh, if things after surgery are not perfect, then in general there probably is a higher risk of the cancer coming back. And by perfect, I mean after the operation. And some of you who have been through this, especially if you're our patient, how we do this. We look at the pathology report. We look at the tumor markers. We obviously look at how you've recovered, how the recovery has gone. We look at the results from circulating tumor DNA, and then we look at the mutations in the tumor, assuming that there was enough cancer left after chemo and radiation, so that the tumor could be studied. And if we have a patient, just like we talked about with the complete response, if we have a patient where the final pathology report shows that all the lymph nodes were normal, they had no cancer in them, the margins that we check were negative, there wasn't cancer at the margin. The circulating tumor DNA was negative, and the tumor markers are all normal. That's what we would say in that patient. We have nothing that's abnormal, and we would probably not apply additional treatment unless there was a clinical trial available. Right now, we have a clinical trial available for that patient. If they have a mutation in a certain gene in their tumor, they would be eligible for a vaccine. If they have something that is not perfect, so if they had a couple positive lymph nodes, if their tumor marker is still elevated, if their circulating tumor DNA was abnormal, then they would be eligible for a clinical trial that we have that's supported by Sina Mangowitz, where we look at targeted agents or drugs designed to treat the specific mutation or mutations in their tumor. And these are oral medications, and typically because it's usually more than one medication, the patient would have to relocate to Milwaukee for 3 or 4 weeks to make sure that the side effects were acceptable, and then they could continue the treatment at home. So that's how we would treat it. If we're more concerned, if despite our best efforts, the pathology was was even more concerning, then we may consider chemotherapy, more traditional chemotherapy after surgery. And certainly for those patients who did not receive much chemotherapy before surgery, it would typically be applied after surgery.
Thank you.
It's a complicated topic, but we try to have general thematic principles that hopefully make sense.
Thank you. Another question, Dr. Evans, do you know any type of targeted therapies for CHEK2 mutation?
Yeah, I think I would refer that to Mandana Kamgar when has she done her session yet?
She'll be speaking on Monday.
Oh, perfect. I would just hold that question for her because she's a real expert there, and that's her main focus of interest, and I think it'll be great to have her answer that.
Great. Another question. If someone has had evidence of distant lymph nodes or systemic disease, but has a normal CA19-9 and then has had surgery, how big of a risk is the break from chemo that would be needed for the person to recover from surgery? How would that break be normally, and would there be a big risk of the cancer coming back during the surgery recovery time?
Yeah, I mean, you bring up a great point. I mean, surgery is stressful, right? I mean, and we, in general, we associate stress with some degree of immunosuppression. So clearly, surgery is good in the fact that it removes the cancer, but in those cases where it may not remove the entire cancer, it may provide an environment where the remaining cancer cells could experience a little bit of a growth advantage. This is somewhat theoretical, but it certainly is something we talk about all the time. But what we do is we try to, for every patient, we try to provide a logical plan of treatment that makes sense. So obviously, if we deliver about 4 months of chemotherapy and then radiation, so that we've done what we think is the best possible treatment. Um, the situation before surgery may not always be perfect. We may have still a lymph node next to the pancreas that might look a little suspicious. We may have an elevated tumor marker, but at that point, in the absence of seeing cancer anywhere else, we would usually proceed with surgery. If then we have a pathology report that isn't perfect, we would try to get the patient back on treatment within 8 weeks or so after the operation. The problem is that pancreas cancer occurs typically in older adults, and people can't, in general, handle multiple treatments in series with cumulative side effects as they get older. Obviously, if someone is in their 60s, that they can usually handle a little bit more treatment than someone in their 70s, who can handle a little bit more treatment than someone in their 80s in general, even though we try not to use age as too much of a predictive factor. But and so therefore, while we would like to give therapy based upon how things are going, if we're going to add surgery at the end, we have to be a little bit careful with how many side effects we deliver, prior to someone's big operation. So we try to find that fine balance, if you will. And that balance is more difficult in patients who may have some medical issues or who are of advanced age.
Thank you. There's a follow-up to that. Can a person with pancreatic cancer live longer than 5 years without having surgery with other treatments?
It certainly has happened. If someone has, for example, a locally inoperable tumor, and they receive chemotherapy and radiation. There are some of those patients who live years. And then for those patients where we take out their tumor and they have a complete response, in other words, there's no viable tumor, the cancer is all completely gone. Well, you could infer that in retrospect, they didn't need the operation, right? If all the cancer was gone. The problem is that that is fairly infrequent. Obviously, the frequency with which that happens to some degree is dependent upon how aggressive the pathologists are in looking through the pancreas tumor. But at our institution, for example, about 5% of patients who have surgery after chemotherapy and radiation, there's no tumor in the that the pathologist can, there's no viable cancer that the pathologist can find. So if I see a patient who has a tumor that I don't think can be safely removed, and there's no cancer anywhere else, I usually tell them that there's about a 5% chance that with chemotherapy and radiation alone that they could be cured. And we certainly do see that. We would love the number to be higher, and we're working really hard to make those numbers go higher.
All right. It looks like Hank. Hank, do you want to go ahead and unmute and ask your question?
Hi, Dr. Evans. Pleasure.
Right.
I am a 4-year survivor and have gone through pretty much all the sequencing that you've been talking about, and thought that maybe it would be relative for those in the audience that I can explain some of the things that I went through. And so I was diagnosed with 1B. They did the Whipple. 21 lymph nodes were all clear. And 10 months later, they found a biopsy in my liver. And it was six pancreatic cells, is what they told me. At that time, I chose to have it radiated, which they did. And that January, which is January of 21, 22, I started chemo, and I did that for 1.5 years. And I was clear for that 1.5 years until I got really sick and was hospitalized and stopped the chemo. And within 6 months, a spot on my mesenteric, a lymph node in my mesenteric area was discovered. I had that radiated in May, and then scanned in June. They found 3 more spots, and they radiated that in September. And so this is where I am. My oncologist has wanted me to go on Zolota, and which is a pill form. So my question to you is with the advent of this really sophisticated scanning systems, I think it's pretty easy, or not easy, but it's easier to detect things so much quicker. And they're getting it down to the little tiny spots there. And if radiation and these other sequencing, if that could keep somebody alive for, periods of time, or does it just become one big mass at one time within a week or something? And which that would be a question.
Yeah, I mean, I think certainly in general, we feel that finding cancer early is better because our treatments may be more effective. Obviously, or maybe not obviously, it's also important to try to treat patients when they're feeling good. It's almost a little counterintuitive. You would think that you need to bring the patient to a near-death experience to have the cancer cell experience the same thing. And we now know that that's not the case, that the patients who benefit the most from treatment are probably those patients who feel okay during their treatment. And in fact, patients who on chemotherapy, maybe some of their symptoms caused by the tumor go away. That's also another sign that the treatment is more effective. So I think finding them when they're small is good. Knowing how to treat someone as complicated as the scenario you describe, knowing how best to treat them, it becomes the art of medicine. And that's where having some doctors that you trust and that you feel comfortable with is probably the most important thing, because it's not the situation that you described doesn't exist in any textbook anywhere. And it's a testimony to the fact that you had really thoughtful doctors who put a lot of time and effort into you and came up with a plan that has seemed to work pretty well.
Thank you.
Any other questions?
I see a lot of familiar faces here, and I just wanted to say hi to everyone, and so kind of you to dial in. Really kind of all of you, and I hope you're all doing really well. I see the boss made it in. Roger, glad you could dial in. Yeah, thank you. So,
Looks like we had another question come through. Roger, you muted, just so you know. What is your opinion of IRE?
in general, I'm not a particular fan of IRE. There certainly are probably those people where it has helped them. I think IRE is irreversible electroporation. I'm probably not pronouncing it correct, but it requires putting some instruments into the pancreas, and that occasionally can be done through the skin, but more commonly is done in the operating room with an operation. And so I think if the same thing can be achieved with radiation therapy, and radiation therapy does not require an operation, so I tend to prefer radiation therapy. I think IRE has also been applied when the tumor cannot be completely removed, but I think removing part of the tumor and then applying IRE, I think the patient may have been just as well served with radiation therapy and no operation. I think just my opinion. There certainly are very smart, talented people in the country who feel that it does have a useful role in the treatment of this disease. I'm just probably not in that camp, but I think it's a good time to bring up the fact that really smart, dedicated physicians can disagree on how individual patients should be treated and what treatments should be used. I mean, that's very common when we have our national meetings and we have case presentations and symposium. I can tell you that really good doctors don't always agree.
Thank you. It looks like Maria has a question. You want to go ahead and unmute, Maria?
Yeah.
Oh, you're unmuted.
Thank you very much. Thanks for the presentation. My question, I'm newly diagnosed and somewhat illiterate in this subject, though I'm learning a lot from you. And I hear you speak, Dr. Evans, about, if there's a few tumors in this location or a particular tumor in that location. In my case, I have innumerable tumors in my liver. And the two tumors in my lung, each of which have different morphology or different genetics, or they're just different.
Well, they may have. I suspect your tumor has probably been sent for genetic analysis, or your doctors may refer to that as next generation sequencing. For those of you who dial into PanCan, they use Know Your Tumor. The company that does that work for them is the company that we work with all the time called Tempus. There are also companies that that do this that are called their names are Caris, Caris, Boston Gene, Foundation Medicine. They all provide excellent genetic analysis of the tumor. There are some very large institutions that try to do it in-house as well, but I think that's probably what you're referring to, is that maybe there was a slight difference in the mutations between the liver and the lung, which certainly can occur. I think in your case, you can ask your doctor also what clinical trials are available. There are certainly some newer medications that are coming out that are very exciting, and I think that would be a good option too. Maybe not the first option. If you're newly diagnosed, they probably want to start with chemotherapy. But while you're undergoing that treatment, there can be now is the time to investigate and plan for the next treatment. That I think that staying one step ahead of the cancer, at least intellectually, is oftentimes very helpful.
Okay, thank you. I just am curious about when I talk to my oncologist and I ask her, well, can we approach the tumor in this location versus the tumor in that location? I don't know where to focus the fight.
I think if you take medication intravenously or by mouth, it will affect your whole body. It affects it gets everything. So, and I'm sure that's the treatment that she is designing without any question. Many of the clinical trials are smaller trials, so they're regional. I think it certainly is more convenient to be treated closer to home. So I think the trials that are most important to evaluate are the ones that are local in your local area, and your oncologist should be aware of those. We have a really brilliant guy here in the Department of Surgery named Anai Kathari, he's a cancer surgeon, but he also is an expert in artificial intelligence. And one of the things he's close to having developed is really a rapid assessment of clinical trial options for every patient who's seen. Also, when your tumor gets analyzed at a genetic level, usually all of the companies provide clinical trial options that are available for those mutations, and they also provide the location of the trial. So that's something that would be, it's a little bit difficult sometimes to navigate how you read those reports. So when you get a report back from, for example, if your tumor biopsy was sent to Tempus or to Foundation Medicine, it may be a little difficult for you to read the report that comes back, but that's where your doctor or their nurse practitioner or PA can help you. And they will include clinical trial options that may be available based on that mutation. And it's very helpful. There are some medical oncologists like Erkut Berzhansky and Mandana Kamgar who happen to be molecular biologists, and they're extremely fluent with all of the genetic mutations and that whole field. But not every medical oncologist is as comfortable with all of that.
Thank you.
Okay.
Thank you. It looks like, do we have a couple more questions, a little bit more time?
I may have to go in about 1 minute just because
Okay.
we're trying to recruit another scientist, and
Sure.
and I'd like him to have one glass of wine before I present the contract. Just soften him
Good
up a little.
idea. So we can take Michael Francis, if you want to go ahead with your question, and then we'll wrap up.
Thank you. Thank you for taking. I spoke with you 6 years ago, Dr. Evans, and you told me that I was non-resectable. I went ahead with Dr. Borzanski at the Virginia Piper Cancer Care Clinic in Phoenix. The reason I'm commenting is because of Lisa. I am a 6-year survivor. I was in the stage 2 trial for the triplet, did 18 weeks of that and 33 days of radiation. And I can still play 9 holes of golf today. So that's my only comment. Thank you.
Yep. Thank you so much for bringing that up, because that's, it's important to note that the things we say, these things happen, and people like you exist. It's so important.
Well, thank
Great.
you so much.
Okay. Great to see everyone. Yeah.
Yeah.
Thank you for all you're doing, and good luck to all of you who are patients and family members.
Thanks everybody for joining. And so we'll continue next week with lectures. So we'll see you all next week, hopefully. And we'll also have these recorded on our website, as I think Olive mentioned. So we'll send out an email once we conclude the series. Thank you so much and have a great night.
Thank you.
Thank you.
Yeah.